Managing a grossly subluxated cataract can be a challenge in the most experienced of hands. Understanding the principles, options, and the techniques of fixation of the capsular bag is imperative in achieving an optimal end result. Now, managing a patient which is preoperatively diagnosed is a planned procedure where the thorough preoperative workup, including an ultrasound biomicroscopy, to evaluate the extent of the subluxation can be performed. In opposed to this, an intraoperative subluxation is an unplanned procedure. Almost always the surgeon cannot anticipate what is the entire extent of the subluxation. I'd like to now share with you what I consider the important surgical principles in the fixation of a grossly subluxated capsular bag. The first thing you need to know what is the exact extent of the subluxation. Having decided that, you need to then find out what is the point of fixation, which should be at the midpoint of the subluxation. I'm interested in teaching the technique of creation of the Hoffman process. A guarded jackknife is taken to make a clear corneal incision at the limbus. From here, you take a reverse inner tunnel, which is performed with the help of a crescent. And what you end up creating is a 2 mm by 2 mm scleral pocket. In these grossly subluxated cataracts, because of the lack of adequate stress, performing a capsulorectus may be difficult. Sometimes you may require capsulorectus forceps in order to propagate these vectors. What we do sometimes find is an excessive rocking movement of the nucleus as well as folds into the anterior capsule. One can use capsular bag hooks to stabilize the capsular bag before the physical emulsification. The number of hooks required depends upon how many and how extensive is the sonnular dialysis. So an important learning here has been the following. When you have a patient with an intraoperative sonnular dialysis, just using iris alone without the use of a CTR may not be adequate because since you cannot tell how extensive is the sonnular dialysis, sometimes even with the most comfortable sacral emulsification with slow motion, the entire bag may be sucked out. So what I really find is useful is that along with the introduction of iriscope, please put in a CPR always because this causes a nice set and a stable capsular bag without any problem. Now, hydrodissection in these grossly subluxated cataracts, I prefer to do after the introduction of the CPR because it gives you a stable bag even for the hydro procedure. Nuclear emulsification is done under slow motion figure with markedly reduced settings. Now, irrigation aspiration we know can be challenging because you have some amount of cortex between the equator and the CTR. So sometimes you need to hold the cortex with the irrigation with the aspiration cannula and drag it towards the open end of the ring before pulling it out. Insertion of the IOL also should be done extremely slowly, carefully, and cautiously. I prefer to put in the IOL in the bag before the CTF for two reasons. One, because it offers protection to the posterior capsule to avoid any accidental damage to the posterior capsule while the passage of the needle. It also allows for assessing how much the scleral suture needs to be tightened by showing you how well stabilized the capsule should be. Iris hooks can be used to retract the iris in the area of fixation. Let's move to the scleral fixation with the CTF. Manual dexterity is paramount because you need to work at any clock hour depending on where the subluxation really is. This is a capsule segment made of 180 degrees of a loop. It has a central loop with an anterior elevation and a tiny eyelet. One of the needles connected to the genopole filter is passed through the eyelid. One needle is passed from the main incision and is exteriorized to come to the eye at a point opposite the points of the proposed fixation. The capsular tension segment is now introduced into the capsular bag and placed well at the point of proposed fixation. The second needle is also similarly exteriorized. Now both needles come to the eye opposite the point of fixation. The capsular hooks are now released to relax the iris a little bit to allow for ease of passage of needles from the ciliary body into the supracapsular space. A 26 gauge tool is introduced 1.8 millimeters behind the limbus via the Hoffman pocket into the supracapsular space. Now, turn by turn, one needle followed by the other are railroaded and exteriorized and come to lie outside. Once both the needles are exteriorized, the needles are cut and the suture ends are kept along. The cut ends of the sutures are removed out of the Hoffman pocket and they are tightened into a 3-1-1 knot. The extent of tightening is just adequate to give you a perfectly centered IOL. And here are the last few learning points. It's better to use a curve rather than straight needles, because these straight needles, while getting exteriorized, can push backwards and actually endanger the posterior capsule, resulting in a posterior capsular retina. The other learning is an ab externo technique, wherein if you were to take the straight long needle directly via the Hoffman pocket to the other side, it is technically rather challenging. And finally, I think we shouldn't be dissatisfied when we successfully end up fixating one part of the capsular bag. While sometimes tightening the suture, you might actually find that the opposite side of the bag is also subluxated. Thus, be prepared to perform a fixation at more than one place and always keep a standby capsular tension segment or a stony ring and another set of features. With this, I come to the end of my presentation. Thank you very much.
Thank you, Dr. Suvira, for a wonderful presentation. You know, bag instability is really a big challenge. So you have two issues. Where would you prefer a segment and where you would prefer a CTR or a Sioni ring?
So, I mean, so any patient that I see mild subluxation, something like 2 or 3 clock hours, sometimes even 4 clock hours, I would get away with a capsule tension ring placed with a hand-on-hand maneuver. Anything more than that, I would use a capsule tension segment. I'm not very comfortable with the Sioni ring. I would rather use 2 capsule tension segments if I need to, but it's almost always, if I have a 5 clock hour subluxation, a capsule tension segment sutured at the midpoint of the subluxation works. The other indication for a capsule tension segment is if you put in a CTR, but you can actually see the edge of the CTR, it means that even though the CTR is in, you've got a bit of a decentration of the bag, and such bags are not stable just being left alone with a CTR. Even in these cases, along with the CTR, I would scleral fixate a capsule tension segment. This is largely my gross demarcation of when I would use a CTR or a capsule tension segment.
Another issue, what would you prefer, segment or scleral fixation haptic itself?
Okay, my experience with scleral fixation of haptics is not that exciting. I don't have that much of an experience. Plus, I would prefer to keep the IOL where it should be in the bag. Exactly. And I'll be happier to fixate the bag in its natural position and then place a lens which is designed for in the bag fixation to remain in the bag. That's just a personal preference. That's what I would do. And if it is beyond the scope of me managing it, I would wholeheartedly hand it over to my retinal colleagues who in our hospital do a scleral fixation of an SFIOL. That's what they do. So I keep a VR standby always, because sometimes you think you can manage, but when you go and assess the situation, it's way out of hand. So I plan the surgery so that they're around, and if I need them to take over, I'm not postponing the surgery for another day. It gets done the same time. And a consent is taken for all of the above, because these cases are sometimes slightly unpredictable, sir.
So I believe the extended
Definitely.
consent is very important in these patients.
Yes, absolutely.
We have to go in for the high risk consent in these patients
Gee, sir.
because they can land up with a long-term complications. So
Yes,
the patient has to go in for the
absolutely.
extended consent. Anything
And for
Dr.
the
Dinesh you want to add?
Hoffman's pocket, I just wanted to know.
Yes,
you are going through the pocket through the sclera full thickness, and then coming out with the needle and then cutting the suture.
Yeah. So
I didn't get
when
that point.
So when you've created your Hoffman pocket, it's very
Yeah.
important. It's very important to know what is the posterior extent of it. Sometimes it's worthwhile
Yeah.
marking it with a blue pen as well. Then
Okay.
you have to stay anterior to that point, correct? Because the suture has to
Yeah,
come
yeah.
out. If you have by accidentally gone beyond the Hoffman pocket, the entire plot is lost. So it's certain that you know what is the correct dimension of your Hoffman pocket. Come slightly anterior to it, be somewhere like 1.5 to 1.8 millimeters behind the limbus. Take a 26 gauge needle, go through the Hoffman pocket, come out through the supracapsular space into the AC behind the iris, and then
Behind
one
the
by one next to each other, bring both the needles out into the air.
Out.
Cut the needles, and then jahan pe aapne pocket banaya hai at the limbus, just drag the sutures out. They come out
No,
at the limbus, and then you tighten it, that knot gets buried. I'd like
But,
to add one more. Ji,
yeah.
sir.
So you will enter twice, no, with the 26 gauge needle.
Yes, twice next to each other, because that's how it'll come
Yeah.
out. But to be
Yeah.
honest, I also find today that if you make a scleral, a shared groove, 1.8 millimeters behind the limbus, that works just as well, sir. Because creating a Hoffman pocket is not very easy. You see, it bleeds so much. Sometimes accessing the posterior extent is. So nowadays, I tend to just make a shared groove 1.8 millimeters, because the aim of all of this is to just bury the suture, right?
Exactly. Thank
So
you,
a
Dr.
shared
Suvira.
groove, it works just as well.
We are running short of time. Can I request Dr.
All right.
Suvira?
Thank you.
Dr. Suvira. Thank you so
very
much. There's a message
Thank
that we
you.
are running
Thank
short
you.
of time.